prolongation of the QT interval is associated with arrhythmia, sudden death, even incident stroke. Now this is absolute prolongation of the QT. What about modest QT prolongation? That is the topic of a paper that happens to be in the November 18th, 25th issue of JACC, and I am with the author, Dr. Saman Nazarian, MD, PhD, Director of the Ventricular Arrhythmia Ablation Service, Johns Hopkins Hospital. Now, this is a MESA analysis. MESA is a rich source of information. Why did you decide to do this study first?
Well, we knew that, as you mentioned, the QT interval, absolute prolongation beyond a certain threshold is associated with sudden death events. And there have also been studies in the past showing that QT interval, even incremental prolongation of the QT interval in people with history of coronary artery disease, in people with known heart disease, is associated with poor outcomes. But what we didn't know is, what does the QT interval mean in healthy individuals, people who are totally apparently healthy, and you get an EKG and you notice that their QT interval is prolonged, somewhat prolonged, maybe not beyond 500 milliseconds, the point where we worry about it. What does that mean? And MESA, as you mentioned, is a very rich source of information. We have outcomes, we have many years of follow-up, and baseline EKGs, and so it seemed like a very nice data source for asking this type of question.
So in the analysis you did, how many patients?
We excluded some patients where we were worried about confounding effects. So, patients that were taking medications that are known to prolong the QT interval, or patients that have left bundle branch block or right bundle branch block that is known to associate with QT prolongation and also with poor outcomes. So we excluded some of those patients. I don't remember the exact numbers off the top of my head, but it's somewhere in the middle of, around 6,500 is the entire population. We excluded 200 people or so for medications. About 300 people, I think, had left bundle branch block. And so we ended up with just over 6,000 participants, which we felt were the appropriate cohort to address this question.
So what did you find, and was it surprising?
Personally, I was surprised. Actually, the person who really should get the credit for this work, Roy Beinart, couldn't make this meeting. He's a fellow who was working with us from Israel. He's back working very hard in Israel now, but he came to me with this idea, and I remember thinking, we see these EKGs all the time. I don't know why it should associate with cardiovascular outcomes. But it seemed like a good idea, and after we went through the papers and saw that there is an association in patients with known heart disease, we thought it was worth looking at it in healthy individuals. And when we did, as I mentioned, I was quite surprised. There's a very strong association. So each 10 millisecond increase in the QT interval is associated with something about 1.1-fold, 1.1 hazard, increased hazard of having a stroke, having poor cardiovascular outcomes, and particularly with heart failure. So completely healthy individual, you see a baseline EKG, they have that has a QT interval prolongation on it. Even modestly, they seem to have a significantly increased chance of heart failure down the road.
I know this wasn't what you set out to do, but why? What would the mechanism be?
Yeah, that's exactly what we struggled with, and I think there could be a lot of different mechanisms at play. As you know, with epidemiologic studies, we can say there's an association. We can't imply causality, and all we can say is there's an association. Now we can hypothesize, and we know that increased sympathetic tone, increased fight or flight hormones, increased sympathetic tone is associated with a direct effect on the QT interval, which is generally prolongation of the QT interval. That's the direct effect. And we also know that increased sympathetic tone is associated with atherosclerosis. There's been many basic studies describing why that may be. And so one possible mechanism that comes to mind is that the QT interval is reflecting the sympathetic tone of an individual. And that sympathetic tone is actually what mediates this association with poor outcomes. Another that we investigated was, is it just a reflection of left ventricular hypertrophy? If someone has higher cardiac mass and they're asymptomatic, then their QT interval is probably going to be longer. More mass, it takes more to repolarize, takes longer to repolarize the heart, and so the QT interval would be prolonged. And that higher mass would be associated with poor outcomes and heart failure down the road. Interestingly, in MESA, one of the great attributes of this cohort is that we have very detailed imaging. So we have MRI data on about 2,000 of these 6,000 participants. And using that MRI data, we showed that it's independent of the effect of left ventricular mass. So it's something else. And we think sympathetic tone is the most likely, but that's not proven by any means. I think we need to look into that further.
Now, this is a substantially sized study, so what does your findings mean in terms of clinical care, management, or screening?
That's a tough issue to approach. I think based on one study, it's tough to change your clinical care, especially if we don't know the mechanism. Dr. Moss, who I respect tremendously, wrote an editorial on our article, which I very much appreciated. And he suggested that if it is indeed sympathetic tone, maybe beta blockade would be something we could think about. And he suggested that certainly more work would be needed to decide if that's appropriate. And I agree with him. I think slow steps need to be taken, but it certainly makes sense that if sympathetic tone is involved, then if we see someone with a modestly prolonged or truly prolonged QT interval, we should treat them with a beta blocker. In fact, that is what we do when the QT interval is very prolonged and we're worried about risk of sudden death. We do treat patients with beta blockers, and that does reduce their risk of arrhythmia. So in this setting, it could have beneficial effects both for the risk of arrhythmia and potentially for development of cardiovascular outcomes down the road.
Wouldn't it at least argue for better management of risk factors?
Absolutely. That would be another, doing some screening tests to make sure we're not dealing with occult coronary disease. The difficulty becomes that if you look, as someone who reads EKGs for our hospital, and I sit in front of a 3-foot pile of EKGs and go through them, I can tell you many patients have prolonged QT intervals. And of course, some of these are in the setting of multiple therapies, but some are just at baseline without medications that would prolong their EKGs. And so it becomes an issue of at what point do you do this? Because the number of patients that you would find would be huge. And you may do more harm by screening tests and finding incidental findings, and even medical therapy. And so I think it deserves more investigation.
Are you going to do anything else? Are you going to look at this?
I would like to do that. It would be a tough study to design. I think it would make sense to try and get funding at least for a type of study where we randomize patients with prolonged QT intervals to more screening tests and or conservative therapy with a low-dose beta blocker, possibly aspirin, and then see if their outcomes are changed. But there are hurdles in designing such a study. The length of follow-up would have to be very long because we don't expect these events to occur for many years. And the number of patients would be large because since they're healthy individuals, the effect that you expect to observe is going to be small.
It is a fascinating paper, and it is in the November 18th, November 25th issue of JACC. It's a combined issue for the holiday. And it is the QT interval is associated with incident cardiovascular events in the multi-ethnic study of atherosclerosis. And as we said, the accompanying commentary by Dr. Arthur Moss for CardioSource World News. I'm Executive Editor Rick McGuire.